So, good afternoon. I'll be discussing regarding the clinical profile, management, and visual outcomes in patients with sarcoid posterior uveitis. I'm not able to change. Sarcoidosis is a multisystem granulomatous disease where 1/3 of the patients present with ocular complaints first. Posterior uveitis occurs in 5 to 28% of the patients, which entails choroidal granulomas, retinal vasculitis, multifocal choroiditis, and optic nerve head lesions. While SPU has been well described, comparative data on the clinical profile, treatment response, and visual outcomes across different lesion types is limited. With this study, we aimed to answer what are the distinct patterns of presentations in SPU, how do different lesions respond to treatment, which lesions carry the highest risk of vision loss, and what is the timeline to resolution or recurrence across lesion subtypes. With this in mind, we conducted a retrospective observational study from 2009 to 24 among 72 eyes of 43 patients with SPU. SPU was noted to be bilateral with a middle-aged onset, often delayed presentation. Patients generally had a relatively preserved vision with a slight female preponderance, and only a small subset had a prior systemic sarcoid diagnosis. Hence, ocular signs are often the first clue to sarcoidosis. We classified the patients based on the revised AIOS classification. Most of the patients fell under the presumed and probable classification. Hence, in real-world setting, SPU is often diagnosed without biopsy. Recognizing ocular clues and ordering relevant systemic workup, hence, is critical. We ruled out tuberculosis by Mantoux and quantiferon TB tests. Serum ACE elevation and bilateral higher lymphadenopathy were diagnostic hallmarks. Lymph node biopsy, although definitive, could not be feasible in all patients. 62.5% of our patients presented with choroidal nodules. 1/3 of the patients had vasculitis, and only a small subset with multifocal choroiditis, optic nerve head granuloma, and papillitis. Hence, choroidal nodules were the most prominent lesion. Coming to the presenting best-corrected visual acuity, vasculitis, choroidal, and optic nerve head granuloma were noted to have a better presenting BCVA compared to papillitis and multifocal choroiditis. Cataract and glaucoma were the most common complications. We also had a small subset with CME, NVE, and NVG. So over 40% of these eyes developed structural complications, underlying the need for close monitoring. We had a patient with BRVO, vasoproliferative tumor, peripapillary CNVM, CRVO, and also an exudative retinal detachment. Oral steroids were used in all the patients, and almost 90% of the patients were started on immunosuppressive. Hence, though steroid remained universal, majority of the patients needed additional immunosuppression tailored to disease severity and response. At 6 months follow-up, 3/4 of the patient had a maintained visual acuity, 15% improved, and 10% showed decline. We classified the patients based on age and gender subtypes. Based on the analysis of this table, younger males were noted to be more likely to present with vasculitis, while older patients showed more of choroidal granulomas. Lesion types also significantly influenced the visual prognosis. Choroidal granulomas and vasculitis responded well to treatment. Multifocal choroiditis required aggressive sustained therapy due to higher risk of vision loss. Early intervention and optic nerve involvement could lead to meaningful recovery. We also determined the lesion-specific treatment outcomes based on activity. We subtyped them into these 4 classes. 80 to 90% of the choroidal granulomas resolved within the 6 months. Vasculitis also had a high response rate. 38% of multifocal choroiditis still remained active after 6 months, which required long-term therapy. All the papillitis cases resolved within 6 months and was highly responsible to steroids and immunosuppression. This is a choroidal granuloma before and after treatment, and a similar FFA and ICG showing resolution of a choroidal granuloma. This is a retinal vasculitis follow-up after treatment. Hence, what is already known about SPU is that it presents with diverse lesion types, and diagnosis often relies on clinical and imaging features. What our study adds is lesion-specific outcomes show multifocal choroiditis has poorer prognosis, papillitis resolve completely, granulomas and vasculitis resolve in 80 to 90% patients by 6 months. Visual decline also correlates with lesion type. In the future prospects, there is a need to develop lesion-based treatment algorithms, long-term immunosuppression strategies for chronic lesions like multifocal choroiditis, and biomarker development for early detection and personalized therapy. Thank you.
Since we have started late, I think we'll keep one question per person. So, with this long
Yes.
duration of retrospective study, out of all these features, which is the most significant one which gives you a clue for sarcoid in our country?
So choroidal nodules were noted to be more common in our patients. So we would say that that is the most predominant lesion. Also in our country, because it is a tuberculous endemic country, we first and foremost need to rule out MAN2 and quantiferon TB gold in our patients. So
Okay, did you do gonioscopy in each cases of
it
sarcoidosis?
was done, sir. We looked for anterior
Did you
significant.
find any new vessels in the angle?
New vessels, one patient had a new
Because
vessel.
it is quite common in the sarcoidosis
Yes, sir.
and the mood of glaucoma.
Yes, sir.
Dr. Ayushi, when did you start immunosuppression for your patients and how did you decide on that these patients need immunosuppression? I mean, were they intolerant to steroid or they were not responding to treatment?
I think, ma'am, most of the patients started in the first visit itself.
With the immunosuppression?
With the steroids with immunosuppression together.
So you started all patients on steroids along with immunosuppression?
Around 90% patient, ma'am. Out of 43, 39 was started on immunosuppressions.
That's a big number because normally these patients respond to steroids, I suppose?
Yes, ma'am. We had started immunosuppression together with steroids in the first
Together
go.
with steroids. Okay.
Thank you.
So can we ask